All right, good evening, everyone. We'll go ahead and get started with tonight's Scleral Lens Education Society webinar with the great Dr. Tom Arnold, Technology and the Scleral Lens Practice. So with that, I'll go ahead and introduce our speaker for tonight, which is Dr. Tom Arnold. Dr. Arnold is a graduate of the University of Houston College of Optometry. During his training, he participated in vision outreach programs in Mexico, Guatemala, and with the Bureau of Indian Health Service. His externship was completed at the IHS Hospital in Santa Fe, New Mexico, and he spent 2 years as a research assistant for the Early Treatment Diabetic Retinopathy Study, ETDRS study, at the University of Texas School of Medicine. He opened his Today's Vision practice in Sugar Land, Texas in 1992. Currently, Dr. Arnold is the Vice President of the Board of Today's Vision Licensing Corporation. Dr. Arnold is passionate about scleral contact lenses and their ability to help patients struggling with compromised vision related to the cornea. He is a fellow of the Scleral Lens Education Society. He, along with Dr. Nate Schramm, organized and moderated the inaugural International Congress of Scleral Contacts in Miami Beach in July 2016. The ICSC was the first meeting in the world dedicated solely to scleral contact lenses. As an international speaker, Dr. Arnold has presented at meetings in the United Kingdom, South Africa, India, Jordan, Colombia, Italy, and Russia. And with that, I will turn it over to our speaker, Dr. Arnold.
Thank you very much, Drew, and thank you, Scleral Lens Education Society, for having me and asking me to do this presentation. Very, very grateful and appreciate the support of everyone there. And let's go in the right direction. These are my disclosures. Hang out with some of these people and help them with their inquiries and products, and also a member of the GPLI Advisory Board. So I think one of the things about scleral lenses is that you have to keep an open mind and not get lulled into a sense of complacency. I love this quote from Stephen Hawking about, the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. And, I tell my externs and the people that come to visit, to keep an open mind. When I was at the early treatment, the ETDRS, early treatment diabetic retinopathy study, the noted retina specialist that I worked for always talked about being a good observer, being a good observer and keeping an open mind. So I think I learn something on scleral lenses every day, which is why they're fun. So scleral lenses, is this really, we're talking about technology, is this something new? Or maybe it's not so new. Maybe it's something old. Let's find out.
This girl is wearing glasses. Don't believe it, but it's true, and here's how it's done. To make contact lenses, the eye is the least size, then Sydney optician Edwin Thomas, Australia's only contact lens maker, inserts the impression cut containing the material for taking account of the entire eyeball. The mold sets in 2 minutes and then it's removed. A perfect impression. Contact lenses are removed to actors or worn by several film stars, jockeys, and athletes. Yes, even glasses are made to measure today. Now the cast is put into a press, and the plastic lens itself is molded. The lens is shaped to fit its wearer's eye, and also to give the same visual correction or aid that would be given by normal glasses. Now the lens is cut to shape from the plastic square, and it's ready for grinding. The plastic is unbreakable, and 2 lenses cost 45 guineas. In America, where the new look is popular, lenses cost 75 pounds. The inside surface of the lens is ground first, a delicate operation demanding a fine degree of precision. The instruments measure accuracy, determining if the lens fulfills its optometric prescription. Then the tiny eyeglass receives a final button. There's still a spectacle case to be lying about, but of course it's smaller, just very hard to find. Lenses are fitted, minor adjustments are made, then a buffer solution is placed on the eyeballs and the lenses are inserted. Contact lenses can be worn for about 6 to 8 hours without discomfort. Slight dizziness after this time can be remedied by removing the lenses for a few minutes. Contact lenses, invisible and comfortable. A new look that's here to stay.
Pretty wild, huh? I thought that was really, really amusing. So we're not so advanced as we may think we are. But we can talk for a minute about impression molding as it stands now. We usually reserve this for, very irregular, very ectatic, asymmetric irregular corneas, asymmetric scleras. And truthfully, a lot of these people that we mold see the value of scleral lenses. Maybe they've been fit elsewhere, but just not right, not the fit and comfort they need. So we turn to impression molding. You get 10 million data points in the scan from the mold, and this gets condensed down to several 100,000 as it actually goes to the lathes. So this technique and this technology is great, for a very precise fit, which you require when you have blebs, maybe tube shunts that you don't want to impinge on, large pterygia. It's a really great technique. We don't worry about the vertical and the horizontal and flattening and steepening because we go to a mold taken directly from the eye. The solution, the plastics have come a long way. It's ophthalmic grade polyvinyl siloxane. And these lenses, once you make them, they're fully customizable. We can make them multifocals. We can decenter the optical zone. I had a case like that recently. We can put prism up to 4 diopters in any direction, and so you get a lot of flexibility in these, and they fit really well. Problem is, of course, they're a little bit more expensive than the conventional scleral lenses, and so we use them in cases like this, really high, very proud grafts that would be hard to fit any other way, and it's a lot more comfortable for the patient too, as we'll see. But you can see here, you got a nice even landing, no compression, no impingement, and nice clearance. Guy still has a pretty good Munson sign, with that proud graft, but he's very, very happy. So from this photo, you can see how the lens is irregular in a sense, but made to exact specifications according to our mold. Very, very comfortable, easy to do. And this is how we do it in the modern era. Now I have the luxury of having great staff, and I have 2 of them doing it. It's just easier, and it's easier for the patient. We just lie them down, have them fixate, and this sets up in about 3 minutes, and then it's removed from the eye. It's a great technique when you're trying to fit a very ectatic or irregular cornea. Instead of putting on 2 or 3 different trial lenses, take one good mold and you're done. So here's an example of that cornea that you saw in the first slide, and you can see the scleral curvature, scleral elevation is quite different. You can see that the limbus is highly irregular, cornea is highly irregular, and notice all the lumps and bumps that we have in here. Look at these little areas here, down in here. You see how this is very, very irregular. Little bump there, which flares out. So really, really great. You get the true shape, you get the real shape, and the lenses fit really well. And then if modifications are necessary, you don't have to remold them. Once this is scanned into the database of the laboratory, then you can sit there and modify it, and they can make you a new lens. Let's spend just a minute on just some examination tips. I'm sure a lot of you out there are pretty experienced fitters at this point, but just some basic techniques let's talk about here. All right, so there we go. So here's the technique. You want to dim the room lights, including your PC monitor, to minimize these reflections. You angle your optical beam about your optic section about 40 degrees. Use white light. Remember that we're looking at the fluorescein layer, the post lens tear layer with fluorescein, but we examine it in white light. And don't use too much magnification. Too little, and you're not going to see the detail, but too much, you're not going to see the overall picture. And of course, this is what we want to look at. We want to look at the lens itself. We want to look at the post lens tear layer, and then the cornea. So an alternative angle is you move your light source over to the other side, and just reverse the position of the oculars and the light source, and then you swing around and you'll see it from a different angle, and this sometimes will reveal a much different picture for you. So in the first picture, the light source is to the side and your oculars are looking straight on, and in the second picture you just reverse the two. So it's a good technique, and I'm just remind you if you're not doing that. We all hear about Ratten filters. You know, we need to use a Ratten filter to excite, you know, the post-lens tear layer, the fluorescein there. And this is kind of what you want to see. You want to see some iris detail. You want to see pupillary detail, not too much, not too little fluorescein. And you want to be sure to clear the limbus and so forth. We do use a Ratten filter. It's a number 12 Ratten filter. If you search for Ratten filters, you'll find there's a bunch of different ones. And the ones we use is the number 12 Ratten. I remember way back in the late 80s when Boston released the Boston Equal Lens, which was one of the first larger diameter, still a corneal RGP, but in the fitting set they include a Ratten filter, and I think I didn't know what to do with it. I kind of looked at it, played with it, and forgot about it. But they're very, very useful in scleral lens fitting. So I urge you to get one. A lot of the fitting sets we get nowadays come with it, so don't throw it away. And of course, we want to look at the post-lens tear layer compared to the thickness of the lens. So all our fitting sets will be labeled with the thickness of the trial lenses. And you want to keep that in mind when examining it. And in most cases, you look for a 1-to-1 ratio. Stephen Vincent and his team down in Brisbane, Australia, sorry, Steve, found that the central clearance decreased an average of about 76 microns over 8 hours, but 50% of this occurred within the first 45 minutes. So when you first put the trial lens on and say, well, this looks acceptable, note the post-lens tear layer thickness compared to the thickness of the lens itself. I send them off and let them do some other testing and scheduling and some information, and I see them back and then notice the difference. How much has that lens settled in 30 to 45 minutes? And you can be assured that it's going to do that once again over the next few hours. So, and then his study indicated that over 2 hours, 75% reduction in that tear layer is going to occur. And this is why on follow-up visits, we always schedule our patients back in the late morning or early afternoon and instruct them that they need to be wearing their lens at least 4 hours when they come in to see us. Excellent article in the Contact Lens and Interior Eye. Something that is not new, but we get asked about this fitting scleral lenses all the time. Do I need an OCT? And my answer, for those of you who know me and have heard me speak, is that I think OCTs are an important part of the modern optometric practice. And there's so many things, obviously, following glaucoma, macular puckering, macular degeneration, all these different things. I think it is part of it. It's nice to have for scleral lens fitting, and I'll show you. But my good friend Ken Pullum, who really is a pioneer in this, and of course those of you who are familiar with him, he's been doing this since the late 70s or early 80s, and he's funny with his quips, and he says an OCT is overly complicated technology. He's making fun of us and says, yeah, you can just examine the eye and look at it. There's a number of different products. They're all real good. They all work. So if you're thinking about getting an OCT, examine what's out there. And I want to thank my friend Ed Boschnick down in Florida, who does amazing things. And I've learned a lot from Ed, and I hope he's listening tonight. But he sent me this picture. Now, this is a great picture, OCT picture of his scleral lens fit over the entire, cornea out to the sclera. However, unfortunately, we're denied this now because this unit is no longer on the market. Hopefully there's some others coming to market, and I'll be sharing that with you in just a minute. So too bad you can't get that. You can get this. This is my picture of the anterior segment. I'm not using this type of picture to fit a contact lens, but to see what's going on with the cornea. You can see this person, if you look to the right under the little blue box, has an intact. And so it makes for an interesting picture. To get this on my unit, you have to use these little auxiliary lenses. You pop these on over the lens where the patient is looking in, and you'll get the picture that we just saw. It's okay. It's it's not great, but and you can. This is also, now this is not with that little picture. This is an anterior segment, and we'll show you how to take this in just a second. This is what they call the global view. And you can see I got some work to do on this fit. You can see that it's riding up nasally and the lens is being decentered a little bit temporally. But it's a pretty good picture, and it gets lets you know what's going on. So I have an OCT. I use it. I like it. And it's good for documentation, as in this picture here. And it's nice for confirming, what you're seeing at the slit lamp. And I always, when I take OCTs, I try to not prejudice myself. I'm looking at the patient. I'm writing down what I think the trial lens is, and what I think it's settled to. And then I'll look at the OCT later for confirmation of what I'm seeing. And it's a learning tool. So say you're looking at the slit lamp and you go, what's that little spot? What's that little area I'm seeing there? Well, it's nice to have an OCT. You can look at it and go, well, something going on with the epithelium there, not sure what, but we think we ought to address it. So it's a useful tool. I like it. It's great for looking at the landings, the different areas of the eye. So if you have one, use it. If you don't have one, get it, but get it for all the right reasons. Now, people will write me or call me and say, they'll look at pictures like we just looked at, and they'll say, how do you do this, Tom? Mine doesn't look like this, or so forth. And so here's some illustrations of the way we do it on our unit. We use the anterior segment 5-line raster. And this is similar to what you use when you're looking at macular scans. You're looking for swelling or edema or detachments, where you look at the macula. But this is the anterior segment version. And you see you have 5 cuts, and you can click between the different cuts. So here's a tip that I learned from Barry Iden, who's been doing this stuff a long time, and is a great keratoconus expert, along with his team out in Chicago. He said, well, don't just do the horizontal. We know that many cones are displaced. They're displaced inferiorly in some manner. So you may not be seeing the highest point of the cone in your horizontal scans. So turn them vertically, turn them 90 degrees, and do a vertical 5-line scan, and make sure that you are getting the clearance you want over the peak of the cornea. And this is how you use the same scan to get the edge profile. Now, purists will say, well, if you're changing the positions of gaze, then you're really not looking at the true relationship of the haptic. And it's very valid, and I think that's a valid statement. But it gives you some idea. You're going to be close, and I just think it helps with your overall evaluation. So here's a little bit of close-up of that vertical scan, what we mean by that. Now, here's a newer generation of OCT, which has a wider field. Dottie Fidel from Rome allowed me to use this, and I'm very grateful to her. But it's a great image, similar to the one that Ed had earlier. And this is very interesting. Dottie is just one of those brilliant doctors who publishes a lot, designs her own scleral lenses. And it's becoming well known, we'll talk about this in a minute, that the limbus is not circular, it's more elliptical in shape, and often the vertical chord of the cornea is shorter than the horizontal chord, or maybe vice versa, but typically it's shorter vertically. So you can see here the chord cut is the same. It's a little over 9 millimeters up, and then but you see that vertically the chord is, if you look at the chord at 90, it's 10.5 millimeters. If you look at it at 180, it's 11.58. So it's more than 1 millimeter difference there. So these kind of units will help you kind of ascertain that, and it helps your fitting. So this is a Ortho K scleral lens that Dottie designed, and this is a great instrument to have. Here it is looking at the edge, and I think you'll agree with me. These are very beautiful pictures. If you look up at the little cube in the upper right, you can see where that scan is taken. But guess what? Not in the U.S. yet. This particular unit comes out of Italy, and it's not FDA approved, but it's definitely on the wish list. All right, let's talk about tomography. Let's talk about Scheimpflug imaging. Many of you may have heard of this, but tomography is different than topography, because tomography is a method of producing a 3-dimensional image of something that's solid, like the human body. So it's a camera system. It's not dependent on the reflection of a tear film. And the advantage of it, one of the many advantages, is you get true elevation data and you get global pachymetry, because we're looking at the cornea as a whole and we're doing depth measurements through it. So I started doing Scheimpflug imaging about 3 years ago, when I really started seeing many patients with keratoconus and managing them. Because another thing, going back to the illusion of knowledge, a quote by Stephen Hawking is, when you fit a lot of scleral lenses and you get enthusiastic like I do, it's easy to concentrate on the lens, fitting the lens and all the things we talk about, and kind of forget that there's an underlying health concern underneath. So we need to be looking at the cornea, looking at progression, looking at swelling, all these different things. So we're managing a disease process. And so Scheimpflug imaging can help us with that. I remember in optometry school learning about Shiner disc. And so I was kind of interested in how old that was. 17th century, quite a while ago. So Shiner was, measuring marbles, looking at the reflection on the surface of a marble. But Placido's disc, came around in the 19th century, and that's really withstood the test of time, because most all topographers work on that principle of that concentric ring or circle of black and white rings from the anterior surface. So, most topographers look like this. They use Placido disc, different scan heads, different sizes, and they're fine. We've all had one. I've had one for years. But when you get with these real difficult corneas, the problem is the tear film, can be very unstable and lead to poor images. I mean, we're looking at dry eyes. We're looking at graft versus host disease, Stevens-Johnson syndrome, and just a real atatic cornea like some of the ones we saw earlier. So it's difficult to image. And remember that we're not fitting the cornea per se. We want to get over the cornea. We're fitting the sclera. And also, they're not going to give you the global pachymetry. So they have a place, but the Scheimpflug is a camera system. And if you see the little segments, if you look right in the upper part where it has these different segments, there's 25 different slices. The camera takes 25 different slices, rotates around. It only takes 2 seconds. This image is the first image I showed you after the impression mold of the very high, the very proud graft. And the problem with topography is that when you have this non-planar surface that really falls away from the apex, you don't get accurate results. And so that's why the Scheimpflug is a very useful tool. And so this would be, Scheimpflug, KSSO, what does this mean? Well, this is a example of the data you get. You get your topography just as you would with the Placido disc system, and those maps can be anything you want, tangential, axial. You get the overall pachymetry, and you get the anterior elevation, which is very important fitting scleral lenses. That's the challenge, is to get over that or align to that. But you also get posterior elevation, because we know in progressive keratoconus, a lot of what's happening is on the posterior surface. So it's really nice to be able to image that. So who is Scheimpflug? I like history, and I thought Scheimpflug. Well, who is Scheimpflug? So I looked him up. So Theodore Scheimpflug was this Austrian army captain who worked extensively on this method of correcting photographs that were skewed. And what his job was, he was in the Austrian military before World War I. And he actually did his work before the war and tragically died a little bit before World War I started. But he was tasked with flying over what would become the enemy lines and taking pictures, of all the troop movements and the trenches and so forth. And he's flying around taking pictures, and of course the Earth is going to fall away, and it's going to lead to unfocused images. So when he has the subject plane that's falling away and it's not aligned with his lens plane or his image plane, then you only get good focus right in the middle of the image, and the peripheral part is blurred. So he developed somehow a method of bringing these together. He found a tangent and brought these images to a common intersection, and that's how he straightened out the image. And so it's a camera system where the object, the subject, and the lens plane are all in line, and you get a good focus. So this is what we call shine fluke imaging. There's several different products on the market that have this, but they all have this common feature. So another picture of different segments. And, you know, when you have advanced keratoconus, it's really nice to be able to see, you know, what really is going on with the cornea. And if you look in the center part of the cornea here, center left, you see how it's very white. When you see white, that's reflected, that's scarring. So you can really kind of look and get a global view real quickly about, well, how well is this person going to see in a contact? I mean, is the scleral lens appropriate, or is it's got too much scarring? It's going to scatter the light, resulting in a poor image. So it gives you a real heads up. So very, very useful tool. And also now on the unit I have, they have a really unique system developed by Michael Bellin and Renato Ambrosio. It's called the BAD display. It is bad, you know. Any Michael Jackson fans out there? So what the BAD does is it takes that most ectatic region of the cornea is really out of normal range, and it takes it out from the elevation map. And this prevents smoothing and leveling of that map. And so that ectatic region really pops out. You can see, well, how does this compare with the normal region of the cornea? In addition, it calculates 6 separate indices and then computes a global algorithm. And the end result is something they call the D value. And if it's greater than 3, then you're pretty assured that this is an abnormal cornea. So this is the concept. When you have a standard best fit sphere, the best fit sphere takes the entire cornea into account. So the flat area gets steepened, the steep area gets flattened, and this is where you get the smoothing process. So with the BAD display, it takes that 3 or 4 millimeter region indicated in the little red dot in the lower right, takes that out and says, okay, I'm not using that irregular region to calculate my best fit sphere. And so as a result, the cone comes out. And so you get global pachymetry, as you see up there in the upper right. You get the front elevation, the back elevation, and then the difference between those. And that shows your ectatic region. You get a corneal thickness spatial profile. And what that means is how much does the corneal thickness change over time, or change from the center to the periphery. And you can see here, it starts out so thin, it doesn't get normal until it hits, almost 8 millimeters out. And then you have percentage thickness increase too. And you can see that the red lines don't fall within, normal values. And the little global indices I was telling you about are on the very bottom there. And that's the front curvature, the back curvature, the pachymetry, the thickness, and all that. And the little global, the D value is highlighted there on the right. And this is 27, right? And we talked about anything over 3 is abnormal. So this is the cornea of the last shine fluke image I showed you with the scarring. All right. So, we have a lot of talk about keratoconus, oh, pellucid. And I think personally, I've misunderstood this for many years. So let's talk about that. And what's in your chair? Is it keratoconus? Is it pellucid? Is that important? This young guy's probably too young to have either, but he might ask you, hey, doc, do I have PMD? I think a lot of you would agree that the kissing doves or the lobster claw that we see here, that's PMD. Look at the rate of change down the bottom. Certainly that's what I thought until really just a few years ago. But that's not the definition of PMD. So it's not kissing doves. It's not lobster claw. All right. And again, Michael Bellin's written about this. Remember that curvature, which is what axial maps, tangential maps measure, that's a reference base. And so you get these asymmetric patterns, in possibly a normal cornea when the apex, the line of sight, and the measurement axis don't line up. So it's a normal variant, it not indicated of any particular pathology. And so, as Bellin says, it's often misdiagnosed. And this is from the Pentacam Interpretation Guide. And so this is PMD. This is where you have that band of inferior thinning along the margin. And of all our patients, I've been doing this about 6 years, not as long as some of the people out there. But I only have, in all the cases I've done of keratoconus, I only have this guy and one other that really have PMD. So it's quite rare, actually. And so here's the axial map that we just looked at, and look at his corneal thickness. So certainly it's a low, almost temporal cone, but it's not that band of thinning. So don't be misled. And does it really matter? Probably not. Although keratoconus tends to arrest itself in the late 20s, early 30s, and PMD seems to go on, and you have changes later in life. So it is an important diagnosis. Any chess players out there? I used to play a lot of chess in college, and stress reliever. I like it. Got to watch out for the queen. She can do anything she wants. Okay, let's talk about the limbus again. We looked at Dottie's excellent OCTs. And the sclera is not symmetrical. It's highly asymmetrical, as is the limbus. This is an excellent paper, and if you didn't read it, I urge you to get it. It's published by a number of friends of mine who are all brilliant. And as you see, it's the assessment of corneal scleral shape, or not corneal, scleral shape patterns using an wide spectrum surface elevation topographer. And do read it. It's very, very good. And this is the results of that study. They had 140 patients. Only 6%, not even 6%, had a scleral shape that you could describe as spherical. Only a little less than 29% were toric regular, meaning that it was against the rule sclera or with the rule sclera in a regular pattern. The vast majority, almost 2/3, were irregular with asymmetric high and low points or a periodicity different than 180. That means it wasn't steeper horizontally than vertically or vertically than horizontally. It wasn't even oblique. There was no discernible pattern to it. And so we wonder why scleral lenses are so hard to fit. Why do they decenter? Why do I get bubbles under this? And this is why. The sclera itself is irregular. Part of the reason why is the circle of Talot, where the extraocular muscles are inserted at different distances from the limbus. And the other reason, I don't have it here in the slide, but the other reason is the sclera is very, very straight. It's not curved like the cornea. Once you get off the limbus onto the sclera, it's a very straight, or what we call tangent surface. And so the lens has to fit that. A couple of illustrations of the technique, a couple of the units. You do use fluorescein in these units, and you're looking at the elevation maps. Okay, remember that in elevation maps, blue is below the plane of the best fit sphere. In this case, the best fit sphere is reference to the sclera. So blue means it's steeper, not flatter, as in axial maps or tangential maps. And then red would be above the plane. So that's your flatter region. So remember to reverse the colors in your mind, if you will. And so this is indicative. This is from Greg Denier, one of the authors of that study, and I appreciate the slide, Greg. And this is what we mean by different asymmetrical high points. So this is we would call this a with the rule scleral shape, in that it's steeper vertically, flatter horizontally. But notice that the two high points are not, there's 200 microns difference, even though they're both the steeper meridian. So this is why sclerals are sometimes very challenging to fit, and we get into controversies. Well, how big should the lens be? Do we need toric haptics? Do I need quadrant specific haptics? We get into all these controversies and conundrums because we're fitting a very irregular surface. Another product here shows the same thing, the steeper and the flatter meridians here. The cornea is the central little circle in the middle. and everything out there is sclera. This is a unit that doesn't require fluorescein. It's using the shine fluid technology, where again it's taking the scans, and it does a pretty good job of getting out there. You see nasally, temporally on the bottom, superior, inferiorly on the top, and they're color coded to the little color illustration in the center, lower center area there. So different instruments, all trying to do the same thing. And here's a few pictures of them. I'm sure at any show you go to, you can talk to the vendors and they'll be happy to demonstrate this. And they have a database of scleral lenses, which really makes them useful. And that is, you can you select your favorite design, and the profilometer will say, well, if you're going to use this lens, then I would start with this sagittal depth, and the haptic ought to be like this. So another example, you have your scan, you have your data, and you look to the left, and there's it scrolls down, and you can, there's a number of different lenses, not just these. You can pick what lens you like and click on it, and it'll give you the suggestions. So I think the ultimate goal, I think for all of us, is to go to empirical fitting, to upload, to take those scans and just upload it to the lab and just say, make me a lens like this. They will fit right the first time, or they're going to be really, really close without the need of going through trials. You don't have to disinfect the trials. You don't have to put them on and off and try different ones. You have to come out with a prescription, which they can probably do from a manifest Spectacle RX, or better yet, and this is how we do with the impression molding, we just put any RGP lens, just something to stick on the eye, known base curve, known power, and just over refract that. And with that calculation, they can make you a lens. So no trial sets, right? No expense, no maintenance, no lost lenses or broken lenses. Or you end up with something like this. These are our trial sets. Now these are, some of these are betas, some of these are old. I don't use all these, obviously. But this is what you end up with. So nobody has room for that. All right, well, we can do all this work. We can do all this analysis. We've got all this great equipment. And if the patient can't get this in their eye, then, it's kind of all for naught, isn't it? So how do we help the patients get this thing in their eye? Brian Tompkins in Northampton, UK, was very nice to make me a slide illustrating this with one of his staff. And, the patients and even some practitioners, when we first look at scleral lenses, they look like this. They don't look much different. They look like, how am I going to put this pizza pie in my eye? Well, there's a number of devices out there that you can use. A little handheld device with a little plunger unit, kind of gives you something to hang on to, a little bit larger. So that's one option. Another one by a young man, Dr. Fayez Magoob, who came up with a really interesting design. This little unit telescopes. You can, you can stand up and use it or put it on a table. It's got its own light source. The battery goes in the central tube. There's a little on-off button on the bottom. You use a DMV that has a hole in it, and it shines right up. And pretty, I don't know if these are on the market yet, but he's certainly going to develop it. We've all used the CMV or the C green inserter. There's several variations of this. We have a couple of these in the office. Sometimes people buy these. Again, it's got a light source and whatever it takes to get it in the eye. And some people have handling issues. Maybe they have rheumatoid arthritis, or they've lost some fingers, or who knows what. Maybe they have Parkinsonism. So this is very, very useful. But you can always be creative, and we call this the Truckstop Inserter. You take your styrofoam cup and punch a hole in it, and make sure your DMV has a hole in it as well, and so it doesn't retain the lens. And use that, works well. And you can get really creative. A patient of mine, in fact, I saw him like yesterday, and we call this the Handyman Inserters. And some of you handymen and handy women out there recognize these are wire nuts used to tie two electrical wires together. And I said, well, that's fine. Just make sure you clean them with alcohol. And they work. You can't deny it. And this illustrates, I'll point out that you want to overfill the lens. You want a positive meniscus to reduce the bubbles in there. So anyway, so that's that. So we sell, just so people have them, we make up this multi-pack and give them a discount. All right, for the couple minutes I have left, what's in the future, right? Well, Sex Pistols came out when I was in optometry school, so I always had an affection for the Sex Pistols. But anyway, Johnny Rotten did pretty well. He married some heiress in the UK worth millions of pounds, and I think his future turned out pretty good for him. But one thing that we hear a lot about, 3D printing, is it real? Somebody thinks so. Johnson & Johnson a couple of years ago, several years ago, almost 3 years, was talking about, printing their soft lenses. And they were working on this. I haven't heard much about this lately, but it's something to think about. And I did run across this. Here's a student in New Zealand who is a psychology major. I mean, he was a psychology student who had a friend with epilepsy, and he was light sensitive. So he said, well, maybe I can come up with a contact lens with some sort of polarization and work on it. And he did. He won a prize down in New Zealand. He got 5,000 New Zealand dollars. He got a scholarship for this. Kind of makes me feel inadequate. Here's a college student making lenses, in his dorm room, eye printing them. So, that could happen with Scleral lenses. There's no denying it. Another innovation, Melissa Barnett drew our attention to earlier this year about drug releasing contacts. Now this is soft, but there's no reason why this maybe couldn't be applied to a Scleral lens. So scientists there in China have developed a lens that releases the drug into the eye, and it changes color as it does so. But as it says here in the last sentence, but only in the area of the iris, not in the pupil. So there's a lot of cool stuff out there. Now, multifocal lenses, okay, it's a challenge. I fit them, and sometimes I have success, and sometimes I don't. But it'd be nice if I didn't have to struggle with it. How about eye drops? Well, there's several things out there. One that gives a pinhole effect, miosis without accommodation. It says it's fairly comfortable. The last 8 hours gives a 5-line improvement in visual acuity. Dr. Habash down in Miami told me about that. This may be a way to go. Sometimes it'd be nice if we could just make them not presbyopic by use of a pinhole effect. The other avenue of attack is softening the lens. We talk a lot about cross-linking the cornea. Well, this is a product of lipoic acid that anti-cross-links collagen, and it allows the natural lens to remain more elastic, and it may even help reduce the progression of cataracts. So you wouldn't want to do this in someone that you cross-linked for the cornea, but it might be something to consider for others to improve their near vision. And it's in clinical trials, and Dick Lindstrom is very influential in the anterior segment cataract world and refractive world, and he's talking about doing some studies on that. So it's pretty interesting. And so I appreciate the SLS inviting me tonight and having me do this presentation. I hope you've enjoyed it. The Scleral Lens Society is one of the sponsors of our 4th annual International Congress of Scleral Contacts that Drew mentioned when we started. This will be a great meeting. It's going to be 2 days. It's in Florida, there at Fort Lauderdale. And with that, these are my contact information. People visit me all the time. People write me. Very, very happy to talk to you. Nick Rumney says hi from the UK. Oh, and join the Scleral Lens practitioners on Facebook. Nate Schramm started this a few years ago, and I'm one of the admins. So get on Scleral Lens practitioners. Great group of people, and you'll learn a lot. And as we say in Scotland, that's me. And I think, Drew, I'll let you take over and tell us about the upcoming webinar series, and I'll be happy to answer any questions.
Thank you, Tom, and thank you for a fantastic presentation. Just one question before we wrap up here. Talk a little bit about your threshold for when you go from a diagnostically fit lens to a molded fit lens. What kind of makes you make that jump from a standard scleral to a custom molded design?
That's a great question. A couple different reasons. Many of them, many patients are referred in by other doctors who, the patient has tried sclerals and they're just not getting the fit or comfort or vision they want. They've tried several and they just, want to take it the next step and achieve the best they can. Others are people that are just, you look at them and they're so ectatic that you go, you say to them, look, I can work on this. I can probably make it work, but it's going to take a lot of visits, and your cornea is very difficult. I think you'll have a much better chance of a quicker outcome, and it ultimately saves you time and money. Especially, we draw patients from great distances sometimes, and they can't keep coming back, especially a difficult case. So a lot of them are what I call scleral lens failures, but they still want it to work, and they just want the best technology out there. The others are, come from a long way and just, need to get it done expediently. And others are just, like I said, they have a big bleb, or they have a shunt, or some real, something really unusual. And you just say, this is the best option for you. So it's a good question. And sometimes they think about it and come back. I have a number of patients, this is interesting, I'm glad for the question, that they only really need this impression mold on one eye, and the other eye can be fit with a regular lens, like a commonly available lens. And they do that because it's the right thing to do and it's more cost effective. But I tell you what, lots of times they'll come back, during the fitting process or at the next exam, 6 months or something, and they'll say, yeah, I know I don't have to have it in my quote good eye, but this impression lens feels so much better. I want one over here too. So they end up getting a pair.
And then to dovetail off that last question, I know on a COPE-approved lecture we can't get too specific on costs, but what is
Sure.
kind of the general difference in cost between impression molded and regular, and then how many, what's kind of difference in return visits and fits for impression molded versus kind of standard scleral lenses?
Yeah, great question. It costs about maybe 40% more, about 40% more. We give them a little bit longer follow-up period, just because it is more expensive. They're more difficult eyes. But I would say it really cuts down on the return visits. Typically, for one of my average patients who, all these people are challenging by definition. That's why they're in sclerals. And I may see, we have a 90-day fit window, for typical patients. For eye print patients, we give them 120 days of impression molding. And a typical patient that, is challenging but not terrible, I'll see them 4 to 6 times within that 90 days, because you got dispense and then 2-week follow-up and so forth. And with the impression molding, maybe you see them twice, 3 times, maybe 4, but it's less. It's really less. And lots of times the changes that you need to do, if you need to do a change, is really minimal. It's really just a tweak. They're not off by much. And usually if they're off by anything, it's usually the RX, that you have to tweak the RX, not the fit. They love the comfort.
And the name of that company?
The comfort is just amazing.
The name of the company is iPrint Pro, I believe. Is that correct?
That is correct.
We have some questions about the name of that company.
Lakewood, Colorado. And that's the website, eyeprintpro.com.
Perfect. We've got a couple requests for Dr. Arnold's email. If he's okay with it, we'll include that in the follow-up email that goes out to everybody tomorrow.
Sure.
And I had one last question. Let me find it again. Oh, the systems that recommend initial starting lenses based on measurements and scleral topography, are they becoming more inclusive of a variety of lenses, or are they pretty specific for a certain design?
They vary. It depends on the brand. Some have a wider range, others are more narrow. So you have to ask. Yeah. Okay. There's 3 major vendors out there doing that.
Very good. I think that's all we have. And I think that'll about do it. So thank you to Dr. Arnold. Thank you to everybody who helped with the webinar. And thank you to all who attended. We'll talk to you all in a few months. Have a good night.